learning more in the ER because everything medicine is a learning curve. Orthopedics I know well, but in ER I am learning total medicine. For an orthopedician, it is easy to learn the medicine. For medicine people, it's very difficult to learn orthopedics because I mastered orthopedics. Medicine is looking very easy, but for other people, it is very difficult to learn orthopedics. So mastering orthopedics is an art. Only for the orthopedician it is possible. So the thing in ER is, first thing is ER CVA. First you have to see the ABC of the patient. ABC, airway, breathing and circulation. Sometimes hemorrhage, particularly from two fractures, pelvis and other femur fractures where the patient rule other injuries also, head, chest and spinal injuries. So always here also you should check the limb neurovascular system. And imaging, most of the time we compromise in imaging, particularly we take APV, we never take lateral view. APV X-ray looks not either 3D CT or for a CT. And always take one joint above, one joint below. If you are missing a joint, you are missing a day of a fracture above one joint, below one joint, you have to take it. It should be there in X-ray. Second thing, and always correct the displacement and angulation and shortening in the ER only. Try to pull it off and put a splint and check the neurovascular system. Immobilize by putting a splint, followed by medications. The most common thing is compound fractures. Compound fracture is a big subject, which is a super specialty in orthopedics. Compound fracture, how to treat? Try to put a dressing and give a tetanus toxide and give an antibiotic proper. So these are all the different splints, and applying splint is an art. Most of the orthopedicians knows, most of the orthopedics doesn't know also. Wow, because they won't put the part joint in what position? Position of stretch, position of ease. Because if you put in an odd position, the joint will contracture. After recovering, the patient will have stiffness. So these are all the splints we can use in orthopedics. But try to cover one joint above, one joint below. So this is a big topic. There was a statement on the top, disposition and the 3 AM ortho consult. What is 3 AM ortho consult? The orthopedician should come at 3 AM in the night. It's an emergency. What is an emergency? So a compound fracture is an emergency. It is an alarm for anybody. So what sort of compound fracture? See, this is a Gustello's, Hanson's and Gustello's classification. Everybody in orthopedics will know, all the PGs will know. But this classification is overcome by the Ganga's score because there are a lot of lacuna in this Gustello's classification. So the Ganga's classification came. So what fractures? Meanwhile, I will say only about these 3 fractures, 3A, 3B, 3C. Why it is an emergency in the ER? The ER people should know why these are happening. There is a saying that don't breathe in front of the bone, but you can spit in the abdomen. But how to close the fracture wounds? Always it is only 5 to 6 hours. So I have seen in Mamata, no people, never I have seen people have closed the wounds within 5 to 6 hours. We have to close the wounds. How to close the gap wounds? We call the plastic surgeon. Is plastic surgeon available? You have to bring him immediately. What sort of flaps you put? There are vascular flaps, free flaps, local flaps, or some other cross-leg flaps you have to put. The flap is a big surgery. It takes minimum 6 hours, 5 to 6 hours in microsurgery. So one orthopedician should know when to put flap, when to close the wound. If you are unable to close the wound, call immediately the plastic surgeon. He will close with a flap or some other thing he will do. Always try to be with plastic surgeon in case of compound fractures. So these are the compound fractures. This is the Ganga pic I have taken from. So here is a degloving injury of the arm with compound fracture of the humerus segmental fracture and supracondylar comminuted fracture. See, I worked in Ganga Hospital under Dr. Raj Sabapati. He works daily 15 hours. He spends 15 hours. He's a ghost surgeon, very good surgeon, very good human being. He operates every day, minimum 15 hours. See, he does more free flaps. So this is a free flap where he has covered that with gracilis flap, not gracilis, it's a latissimus dorsi pedicle flap, and immediately they have done plating. This is very daily. Nobody in the world will do except Ganga people. So they have put three things in this, three plates they have put. Here in Kamam, if you put three plates, it will get deployment. Radical debridement followed by fixation followed by flap cover. What flap cover? Invariably you have to put a free flap. Why free flap? Free flap will have a vessel. So try to put a free flap, not other flaps in case of common fractures. So this is a flap where there was a reverse flap, reversible lateral flap here. So can you see the movement? She is having fantastic movement. So it is the flap that gives the fantastic movement. So always try to assess. And one thing, once the patient enters into the casualty, always see the patient's age, what productivity patient is having. Generally I will assess the patient on the basis of age, whether he is useful for the country, for the family, on him, country is dependent on him. So spinal cord injuries, incomplete, complete, paraplegic, all tetraplegic and all, immobilize immediately and go for the surgery immediately. And try to give 1 gram methylprednisolone bolus and followed by IV, slowly give for 6 hours, another 1 gram methylprednisolone. Within a span of 12 hours, give 3 grams methylprednisolone to reduce edema. Try to fix it. All spine cases try to fix it. Even if the quadriplegia, if there is a quadriplegia or tetraplegia, if it won't recover, also try to fix because make the patient mobilize on the wheelchair or stretcher. Starting point and ending point. If you make customer happy, he will bring another 10 patients. So these principles apply for this. So always try to be a team effort. So always you alert. Even a ward boy is a team. Even a nurse is a team. Assisting fellow is a team. My assistant is with me for the past 25 years. Without my assistant, I can't operate. So beyond. So sometimes what happens? Patient comes to the ER. Sometimes you don't know what to do. Patient is in sick, he's in shock, but everything looks normal. So we have to think beyond the box. Out of the box, we have to think. What is there? Easier comes so that we can come to a conclusion. Always use AI in the ER because sometimes we are blind because we don't have any diagnosis. We will have a dead end. At the time we use AI will show the way. It will assist you. It is not AI which dominates in the future, it is AI which assists research. So second thing, resuscitations. Always the principle won't lies with ABC. Sometimes CAB comes, sometimes March comes. March is bleeding. In most of the aspects, recently in Turkey, what happens, they have no, because of bleeding falls, patient hands, so many amputations. People died. Why they died? Because they are not having tourniquets. So in our ER, we should have a number of tourniquets. Because don't expect any time some building collapses, if 20 patient comes. We should have 20 tourniquets. Immediately you apply tourniquet, you will save the patient from hemorrhage. So first give taxamic acid, try to put tourniquet, and try to treat the primary cause. What is the future for the ED smarter? What is the future? These are all the things. See, in ED, the ED physician should be take the patient outside. On the bedside, how to assess, how to come to a conclusion. One is focus. Focus is, what is focus? Can anybody tell? Point of care ultrasound. It's a short, small machine where you can know the bleeding from the spleen, from the liver, from the abdomen, around the heart, and also in the lungs and the pneumothorax. By that you can come to a conclusion. Instead of taking to the CT scan or faraway place, you are wasting time. Only limitation for focus is patient will be in shock. You can't do the cardiac massage or what? What is that called? Cardiac massage. What is that called? This interaction session I told you. Patient is in shock. What do you do? CPR. So the only drawback in case of focus is in CPR. While doing CPR, you can't do. What other things you can do? You can go for rush. What is rush? Rapid ultrasound in case of shock and hypovolemia. You should know where is the shock, where is the bleeding, either from the lung or heart or some other thing. And the other thing, E-fast. E-fast is one of the best. What it will do, it is also a sonogram where you will know all the areas of bleeding. So these are all the things we can assess immediately on the bedside without getting to the latest investigations like CT scan, MRI, 3D CT and all. So, and also we have a point of care diagnostic. What is point of care? Get the investigation bedside within 5 minutes. We can assess the patient what his condition is physically and hemodynamically. And what Tegrit, the Chinese premier came to know about that. He covered the Wuhan. It was the Chinese who covered it. No other country should have covered it. It was China which controls the coronavirus very well, but even then it spread throughout the world. So you have to be careful. It is prevention which is better than cure. Always don't write in 3 phases. One from Bombay Dockyard, another from Delhi, another from Calcutta, another from Delhi. 3 waves, many people died. Probably because we don't have connection for the generation, we don't know. But many people died in India. So this is the plan. This is the plan to try to avoid deforestation, try to plant trees, try to save the world, try to save the planet, and try to save yourself. So this is the picture in Turkey. So why I kept this picture is the triage is more important. They use 2 triages. One is they bring the patient immediately to the care picture. What they do is they diagnose near the red is emergency, yellow is mild, moderate emergency, green is normal. But the problem in earthquakes is the green fellow who walks completely will die on the 3rd day. Why? Because the buildings collapses, most of them limbs will have a crush syndrome. The crush syndrome will develop, what they develop crush syndrome? They develop myoglobinuria and develop renal failure on the 3rd day. So why? In these cases, AI is very important. How AI is important? It will monitor their investigation pattern so that they will bring back to them. Their cell phone is connected to the AI. So AI will inform the local physician and the local hospital so that we can bring back that fellow. So don't ignore in the triage when you keep some fellow in green priority, don't think he is normal. Sometimes you may go home, come back with complication or death. So always try in earthquake it is possible because there is a crush syndrome. Patient will walk, but he will develop crush syndrome and will die because of renal failure. So the other thing is why because of World War I and World War II are the 2 world wars where the orthopedics developed. Before that World Wars there is no orthopedics, there is no department. Orthopedics came only in World War I and II. All the punctures, nail plates and AO system came only after the World Wars. Any war will develop. Now the Ukraine war is developing what? All the drones now. Number of drones are coming. China has used all the systems during Corona. They have 3-4. You should know about. We know about the Google system. China is having Baidu system, and they have Alibaba system. China used everything because they monitor every corner of the world of China. If somebody is having temperature, that will pick up and it will immediately come to the local physician. The local physician will catch that fellow and he will take to the SL. So this is the pangolin animal that caused coronavirus that disturbed our economics for 20 years. God only knows how many. This is the one temperature blade. So these things China kept everywhere during Corona and controlled it. This is the robo. So it's the robo. They use the robo in ER. They use the robo in while cooking. They use the robo while changing the clothes. They use the robo during sanitization. So everything is technology. AI is using the principle of AI. So one who has to change technology. See, Indian CEOs are the best in the world. In America, if you see the top 10 CEOs, they are from IITs. But in our medical system, we are not following that. So India has to change it. It has to follow China because we have to follow AI and the robotic system and the drone system in the medical because we don't know where the pandemic comes because 19 lakh viruses are coming and the terrorists are always ready and the earthquakes because of climate change, climate mitigation because of different issues, we have to face the problem. There is no peace for us. We have to fight against all odds.
A well thought-provoking lecture. It is beyond the evening, it's into the future. So now I request everyone to stay for a few more minutes for the inauguration and then followed by the tea break. Now I request K. Manjunath sir, Professor HOD, to occupy the dais. Now I request Amantha sir, Professor, Emergency Department, to occupy the dais. Lamp lighting and start the formal inauguration of the Emergency Medicine CME. This is the first CME. We have the first department started in 2023 and we got permission 2024, and we have the first batch of students joining 2025. So this is the first CME. So to seek the blessing, we will start with the lamp lighting. Now I request our principal madam. And everyone used to scout and defend our hospital in the times of emergency. With the coming times and changing need, so the new emergency medicine department has evolved, and now we are working in collaboration with the Department of General Medicine and General Surgery as a team, and conquering the new frontiers and changing the way the patient gets the treatment in the, like golden hour, platinum minutes, and increasing the patient care. So now I request our principal madam to say a few words regarding this.
Good afternoon, everyone. At the outset, let me congratulate the Department of Emergency Medicine, HOD Dr. Mahendra Kumar, Dr. Hanmantrao, and all the faculty and PGs for coming forward to organize this CME program. And the topics are very nice. They are not confined to the emergency medicine, but it is the need of the hour. Every postgraduate, every doctor need to know about this topic. Because every time patient comes to the casualty, I used to observe there is a confusion. Who will attend that patient? Is it emergency medicine case? You take up the case. It is not anybody's field. Everybody has to learn the important emergencies, how to manage. Because all the PGs are the first hand or primary care physicians, you will come in contact with the patients at any time. So you must know how to handle these emergencies, how to manage the patients. Along with the postgraduates, even the paramedical staff, it is also very important for them to know. It is nice to see the paramedical staff here and the interns and unfortunately few postgraduates. I'm saying only few postgraduates, but we invited all the PGs of all departments. I don't know what busy they are having. It is nobody will call you and tell you at any time, all the time, nobody will teach you one-to-one. So it is a place where you have to update your knowledge, update your skills in the treatment of the patients. Because day by day, a lot of things are evolving, new changes are coming. As Dr. Mahendra Kumar said, now AI is coming to picture. So all these things you cannot learn or mug up by reading the textbooks by sitting in the library. You have to learn by the observations or the experience of your senior faculty, and by learning from them, you have to learn these things. It's not simply by sitting in the library you cannot learn. So you must attend such CME programs to update your knowledge, and also you have to listen to your seniors. They are sharing their experiences, how they are managing the emergencies. And I appreciate Emergency Medicine Department. They are helping us in organizing many things in our college. They are helping us in organizing this BLS and ACLS training programs for postgraduates and interns. There are also, and we have a very beautiful simulation laboratory given by our management. We are posting our students.
Now I request Dr. Ramaswamy Superintendent to say a few words.
I think this is the first academic curriculum in Department of Emergency Medicine. I think why these CMEs they have to conduct just to support both resident and topics. Sir has mentioned so many things. See, till now I was knowing only that deforestation can cause global warming. But sir has mentioned that 19 lakh viruses are waiting to attack human being. It's not a joke, but in like this like updates, if we come to know that at least not even 100%, at least nearby we can reach. So don't miss any lecturers and any CMEs, any like guest lecturers. Please do attend. And we have noticed that few departments they're not attending properly, like both hospital, clinic, and academic also. Last time scientific program also there was attendance was so less. So why have to conduct all this? Because of you, and we want to so something to interest towards academic. But without academic, only hospital side, nothing. It has both learning and earning, and sharing the knowledge is most important. Please do attend to all the CMEs, and some department they are not concerned about morning rounds and evening rounds also. I want to say the out of the topic, but I want to mention few things. Some departments are neglecting the patients, and this is not good. But morning and evening rounds are mandatory for resident. For resident, there is no duty hours, 9 to 4, nothing like only in the morning 9 o'clock. Next day 9 o'clock they are attending the patient. It's so like attending the patient. Please don't do that. So after your duty hours, after 6 updates, see usually some investigation will be advising in the morning. Maybe it will come by evening, right? So go through that all the investigation, update the condition of the patient to your station. So usually something goes wrong, definitely the patient attendance will make some drama in the hospital, right? They don't know that, especially general medicines. You can't see anybody from the department, general medicine department. So please don't do that. Show some empathy towards the patient. So that is the most important, right? I think this is a trial of CME. So upcoming days, just teaser, and next week we will be coming in the month of January. Yeah. So that will be the biggest CME will be conducted by Department of Emergency Medicines. So Avis, the topics are very good. So in coming days, they will be important topics we will cover definitely in the coming days. Staff and especially you guys. It's support required from your side. So learn all the things. Okay, don't neglect anything. See, suppose hey, general medicine, nothing is good for us. See the.
Or Mahendra sir will say a few words on this occasion.
Good evening, everybody. Thank you for coming here. Sir already showed empathy. So any doctor should have 3 things: humility, empathy. I practice in Kannam. Every day, some nearly 10 patients quotes me. Of late, I won't talk anything with the patient. I will say, even though patient is wrong, I will say I am wrong. Because there is no point in discussion, because I don't want to waste my time. So always have humility. If somebody scolds, don't think, don't try to answer to them. Just keep quiet. If you keep quiet, that is an asset. Keep the tongue in center. Don't deviate to the point. If you keep your tongue in center with your partner also, life partner, mother, father, in-laws, particularly in-laws, you will be very useful. The second thing, see, we are here, I am an orthopedician. For learning orthopedics, I took 30 years. Even now I am learning. In emergency, I am learning everything. So, to the management of Mamata and Principal Madam is my family friend, and she is my senior in medical college. Sir is non-Kannada. So one thing you should know is, we are master. I am not a master. I know 1% of orthopedics. But if you know the father of pre-modern medicine, Ibn Sina, IBN SI. Ibn Sina is from Samarkand, the so-called Persian Empire. He wrote 4 volumes of book, which were Bibles until 1600. Even Latin America translated them. He had everything written on the book with picture. Ibn Sina is a polymath. What is a polymath? He is father of astronomy, father of physics, father of alchemistry, chemistry, father of science, everything. He used to do surgeries. Those were the days they were invented and they discovered, and they are the masters in that. Now I am not master in that, but I am speaking. So think about the old people, Aristotle, everybody. So how they worked hard. So we are not working hard to that level. So he's a good surgeon, very good surgeon. He does polytransplants. Polytransplants means 2 kidneys, 1 pancreas, liver. He do transplants, multiple transplants one time. It's a very big sign. He's from Japan. He settled in America. So he works daily. He operates minimum 12 to 16 hours like that. He trained 169 surgeons all over the world. He was a marathon runner. He's a marathon runner. He runs 40 to 50 kilometers in a marathon continuously. He's around 65 years old. He thought he won't get COVID. He got COVID. He thought he will never die. He was in deathbed. All his 169 disciples came. They closed the hospital and they made him survive. Because every day he will have one patent under his name in surgery. He does every day he will have one technique. So such were the leading techniques. Always try to learn from bigger people. So you have a big goal. Small goal is very bad. Big goal. Work hard. Humility. Humanity. In Western world, in America, if you want to get into medicine, you need empathy. You should be best athlete. You should have extracurricular activity. You are academically good. But in India, we are academically good, remaining on bad. So you should have an all-round personality to develop. It is not only reading medicine that is. You should know how to talk with the patient. Talking is a big deal. How to represent yourself is a big deal. So learn from the seniors. I was seeing people from John Hopkins, one radiology. I know one radiology PG who was sent to Japan to learn how to talk with patients. To a top consultant in Japan. Americans are very, very intelligent. Why they are intelligent? Out of 100 people in school, 90% will be dropouts, only 10 will come. America runs on the 10 people. So we need people who are having quality, not quantity. In India now we had quantity, no quality. So AI is coming, you have to compete with AI. The race is going fast. So you have to read every time, do hard work, try to expand yourself, try to think out of box, and try to imagine yourself what is your personality. If you are 50%, try to be 60%. If you are 60, improve yourself 70 like that. Go on improving yourself. So thank you for giving this opportunity. Thank you very much. Thank you, sir. Thank you. And thank you to all my department people who are so nice to me. Okay? Thank you.
Thank you, sir. Now I request sir to say a few words.
Go for tea break.
Okay, now I request our PGs to present the small mementos of token flowers to the principal ma'am, to the MSR, and to the bishop. Bhavani, Jai sir. I request Bhavani to present the flower to the principal ma'am. Now I request Jai sir to present flower to the superintendent sir. Now I request Divya to present flower to the students. Now I request Jai sir to present flower to the students. I request everyone to have the tea break and please come back after 15 minutes. I thank everyone. I also request everyone to be present after the session. We have a very interesting session on trauma and ECGs, killer ECGs, and what to do in the event of white side sticks. Okay, 3 more important sessions are there. Please come back, have a break. Please come back. Thank you. SR, Department of Emergency Medicine, MD Emergency Medicine from Kamini Medical College. So to give us the lecture on trauma and how to manage. Now I give the mic.
Thank you, sir. So, good evening, one and all. My topic today is first touch and final outcome. So, why is it important for everybody to know the initial trauma? Number one cause of death in the younger age groups, that is age 146 and by trauma 1 to 46, and by trauma we mean unintentional injuries. Those are your major causes are road traffic accidents, and next are falls. And age-wise burden are significantly increased by year because of the trauma. And coming to the coming statistics in India, there has been a significant increase in deaths from 2016 to 2022 because of trauma, and the disease burden has been increased because of trauma from the year up until the year 2016. You can see the blue is communicable diseases. In 1990, where the communicable diseases disease burden is more, whereas coming to 2016, the death from the trauma has been disease burden of trauma used at any center, and even at a primary or a tertiary center, we can use these approaches. So then comes into your picture called Advanced Trauma Life Support, which was started by American College of Surgeons in the year 1980, and which has been now taught over more than 1 million clinicians in more than 80 countries around the world. So what are the objectives of this ATLS? To assess the patient's condition rapidly and accurately using a standard algorithm, and to recognize, prioritize and manage life-threatening injuries, determine whether the specific management needs of a patient exceed the resources of the facility and or the capability of the clinician, encourage effective teamwork and humanistic. So ATLS majorly concentrates on 3 concepts. First, you treat the greatest threat to life. And second is, lack of definitive diagnosis should not delay your treatment in trauma. And there is no need for a detailed history to manage a trauma case or acutely severely injured patients. The primary survey, adjuvants into the primary survey, re-evaluation, secondary survey, and determination for the need for transfer or and definitive care. Today we are just going to concentrate on the primary. So what is examination injury? And next, one of the most important thing in pre-hospital thing is triage. And patients with any risk factors or suspicion of child abuse, dropping off the patient, they can give the hand, that is MS for mechanism of injury, and IS for injuries and related complaints and signs and symptoms, and treatment which was given on the way and how the patient has responded. And the organizing team at the hospital should have clear roles assigned, and they should have a closed loop communication, and they should relate information without any judgment or fear, and you should constantly re-evaluate your patients. And so you can, situation of XABCDE, how have you managed airway, breathing, circulation and disability and environment, and background of the patient, and current status, physiological status and response to whatever interventions, and recommendations, what recommendations do you give to the definitive care unit. And your primary survey includes simultaneous resuscitation. Please keep in mind, primary surveys always goes hand in hand with your resuscitation. You are assessing the patient and you are simultaneously giving orders to your team leader, team members to how to or what to give. Circulation, hemorrhage control and management of shock, disability, exposure and environmental control. So the compound fractures or declubbing injuries. And so how do you control this? The mainstay is to apply tourniquet or wound packing or suturing or clipping. So this is how one can apply, one can control the bleeding. As you can see in picture 1, you can apply direct pressure over the wound with a sterile piece of dressing and elevate the limb. And the third picture you can see that a tourniquet is applied a few inches above the wound and it is tightened. And you can see any external laceration injuries which often lead to your massive bleeding like scalp lacerations and all can be sutured or clipped in the ear. And your airway maintenance with cervical spine motion restriction, you can determine the patency of the airway. How will you determine the patency of the airway of the patient? See if the patient is conscious or not. See if the patient is talking in a clear sentences or not. See if there is any foreign body in the airway or not. Or see if there is any pooling of secretions, any blood or saliva, etc. And once you determine and you feel. And this is the picture showing manual inline stabilization. So, manual inline stabilization. So here he is placing his both hands over the scapular blades of the patient, stabilizing the C-spine. This is done until a C-collar is applied to the patient. And this is a C-collar, cervical collar application. First is a posterior method, and there are two methods, and the second is anterior method. And you can see one person is stabilizing the head at the head while the other is placing the C-collar. Second, coming to breathing and ventilation. Not just airway patency is important for adequate oxygen gases exchange. Of these chest injuries always utilizes a look, listen and feel approach. And adjuvants used are oximetry, chest radiographs and other adjuvants. So all injured patients must presumptively given O2 to prevent hypoventilation and hypoxia, and it has been shown beneficial for the patient. And the more where the foil is placed over an open chest wound and it is sealed over all three sides and one side it is kept open. So this prevents air entry into the chest while there is during inspiration. This is in an open pneumothorax. And this is a chest tube inserted patient for hemothorax and pneumothorax patients. And coming to circulation, and identify and address the circulatory compromise promptly, and it is very crucial in achieving the successful outcomes. So shock is, you cannot just diagnose shock with just a lab or a thing. You need a combination of clinical assessment and also physiological values and also appropriate agents to diagnose shock. And shock is clinically defined as insufficient tissue perfusion and oxygenation. And in trauma cases, hemorrhage is the most common cause of shock. And other causes can be seen in trauma are obstructive because of tension and tension pneumothorax and cardiac tamponade. And directly cardiac injuries, blunt cardiac injury or myocardial infarction. And distributive types, neurogenic shock and septic shock and anaphylactic shocks. And the first clinical, and this is the right kidney, and the arrow pointing is Morrison's pouch. And on the right side, you can see there is a free fluid, that is a hypoechoic fluid. And seeing that the thing that is floating, the tip is caudate tip of the liver, and there is fluid between the kidney and the liver. So that is positive EFAS, we say. And this is the left upper quadrant. The normal is this. This is the left kidney and the spleen. And this is diaphragm and lung, mirror, heart. And you can see there is a minimal fluid present between the spleen and the kidney there. And the left side you can see bladder, uterus and rectum of normal focus appearance in females, and that is the normal focus appearance of males. And you see there is a longitudinal free fluid present in males here, bladder there, and there's a pouch of Douglas you can see a free fluid there in a female patient. Indicates probable bladder injury or your pelvis injury. And then this is a normal heart, you can see RV, LV and dilating walls, etc. And pericardium, there is no fluid in the pericardial fluid. But on the left, on the right side, you can see there is a minimal fluid, there is a fluid around the heart, that is pericardium, leading to tamponade. And this is your, on the right side, you can see a white line moving, that is a lung sliding sign, pleura, which indicates normal lung, there is no pneumothorax. And this is absent lung slide, and that is a barcode sign. And previously, normal is a seashore sign. Sky, ocean, and beach is a seashore sign, which is normal lung when there is no pneumothorax. While barcode sign indicates there is a pneumothorax in the patient. We need to early hemorrhage control and restoration of the circulation via appropriate fluid administration. And always remember blood. If yours has no role in treating hemorrhagic shock, and your goal of blood product ratio should be 1:1:1, that is PRBCs to plasma products to platelets. And tranexamic acid, when given within 3 hours of injury, has proven to reduce the mortality in most of the patients. So you can give 1 gram over 10 minutes and another 1 gram over 8 hours. Or you can give directly 2 grams immediately on arrival to the ER. And always remember, any trauma patient comes, always have 2 IV lines of large bore, that is 16 gauze. And if for any reason you are unable to put IV cannula, then you can have an IO insertion, intraosseous insertion of the line in multiple areas indicating diffuse axonal injury. And diffuse axonal injury is both radiological and clinically placed diagnosis. You cannot rule out DAI just based on CT alone or just clinically alone. You need both for diagnosis of DAI. And coming to spinal cord injury, mechanisms include direct injury, penetrating or blunt, compressions from many hematomas or many patients with cervical spondylitis or osteoarthritis. The cord is tethered or compressed, and contusions or any vascular injuries. So most 31% of SCIs present with incomplete tetraplegia. So the other two things that you should keep in mind, the spinal shock and neurogenic shock, both are not the same. Spinal shock indicates the temporary violence, please stop them or use reversal agents as possible. And tranexamic acid, as we discussed, if given early, it is said to reduce the mortality, especially in traumatic brain injury patients. And analgesia and sedation, properly sedate and sometimes also paralyze the patients in traumatic brain injury, because proper analgesia and sedation is said to decrease the ICD. And preferred drugs are propofol and fentanyl because these are short acting, so that it gives neurosurgeons or neurophysicians to give ideal time to re-examine the patient from time to time. And the next thing is hyperosmolar therapy and anti-seizure therapy. And hyperosmolar therapy, we can use both mannitol or 3% NaCl. Both are shown to be effective. And these are the ideal optimal values that has to be maintained in TDA. Out of them, we are just going to say that your saturation should be more than 94% and your systolic blood pressure should be around 100 mm Hg, and your pH should be maintained normally, and your platelet should be around 6. You should be careful while using mannitol because it is said to, if the patient is having hypotension, it is said to aggravate the hypotension. Okay, and while administering hypertonic saline, preferably use a central line. If not available, you can cautiously give it via peripheral line. And coming to exposure and environmental threats, our main goal today is we are going to discuss about hypothermia, but goal is to fully expose the patient and see if we are missing any other externally visible injuries. And just like we said, if there is a hypothermia or hyperthermia, to also treat those patients, we treat those conditions, we use this exposure. So just today we are going to talk about hypothermia. And hypothermia is when your core temperature is less than 35 degrees centigrade, and every traumatic patient or severely injured patient will ask, you should suspect hypothermia because of the exposure in the and giving warm IV fluids to the patient. If the patient temperature falls between 24 to 28, patient is unconscious, but vital signs are still present. Here, you will evoke the patient with extracorporeal setup if available at your institute. And if your temperature falls less than 24 degrees, there are no. You can give 125 ml of liver racket per hour, and 6 to 12 years you can give 250, and more than 13 years you can give 500 ml of liver racket. And how will you do exposure? Remove all clothing, jewelry, pre-hospital dressing, and identify any external signs that you have missed previously, like abrasions, contusion. If the patient is if you are suspecting patient of a spinal injury, then always block the patient while maintaining the C-spine to examine the posterior aspect of the patients. And what can be done to introduce a spine mode, to stabilize the spine until the patient has come to your hospital or you have transferred patient to a definitive care, or you can do the long run to examine the posterior aspect just like we discussed. So you need actually 4 people or 3 people, sometimes 3 people is also enough.
It's a 3 days course. You have to pay 25,000 to 30,000, and the course starts morning 8 o'clock and ends at 6 o'clock. So trauma, now recently 11th edition of the trauma guidelines have come. So according to that, we have covered. Now I request next presenter, Dr. Pranav, onto the stage. The healthy rhythms. Now I give the mic.
Thank you, Sanjay sir, for your time. Good to be here. Okay, so why we should know this ECG? There is no time, so I will rush a little bit. So why we should know these rhythms? Why all clinicians, all ICU staff, all critical care team, they should know. Suddenly the ECG will be normal on the monitors and suddenly it will change. If you don't see it, I would like all the PGs and my staff to be little interactive. I'll ask some question also in between. Okay. Before we move, we should know our normal. How the normal is generates. Can you see the picture? So here, SA node, AV node, then all this comes. If SNL is working, what will come on ECG? P wave. P wave will come, right? If SA is working, P wave will come. But SA got blocks, what will happen? QRST will come. So what is the norm? It was junctional level. But you should remember what? All the normal sinus rhythm, it should be always with P waves. And P wave morphology is written there. P duration is 3 a small box. Pointer is it? Only the pointer. Okay, she will ask. So next time, next 7. What you have to do is master the monitor and treat first. Don't leave the patient and go somewhere else, because this rhythm will change. Patient will have a cardiac arrest. And never forget your ABC. See your patient, assess your patient. So all this in this slides I will cover 7 ECGs, and then you see the determine stability. Patient is stable, unstable, and next you try your treatment. So once you have ECG rhythm in your hand, either by defibrillator or you are seeing in the monitors, or you have a 12-inch ECG in your hand. Next you ask for 5 things. Those 5 things are: how is the rate? How is this rate? If rate is too fast or rate is too slow. What is the normal heart rate? Range? All of it. 60 to 100. So too low, it is 40, 30. What is this? Some bradyarrhythmias. Too high, 150, 200. Tachyarrhythmias. Arrhythmia means abnormal rhythm. So you should see that. First thing is, take your hand and see the rate. How is the rate? Next you see the rhythm. How is the rhythm? Rhythm, it should be regular. Regular means every time R wave will be the same place. This is R, every time it will be the same time. It can't be irregular. That means something wrong with this ECG, something is going on. So you should alert, the brain should be alert. Is it regular? Irregular. Next thing, P wave is there or not? P wave is there means it's the wave is coming from SA node and P is coming on ECG. If it's not there, again it's not a normal rhythm. Your brain should, okay, what is this rhythm? Where it is going, where is it leading? And P is there, then you see PR wave. PR normal 3 to 5 small box. PR main distance is 3 to 5 small box. Is it normal or is it prolonged? Basically, it will prolong it where? Which condition will prolong? Bradyarrhythmias. And narrow image condition, tachyarrhythmias. So your brain should ask for it. And on the basis of QRS complex, what is the normal QRS? 3 small box, normal within 3 small box. But it got widened. It got widened means there's something wrong. And too narrow also something wrong. Once you decided the CCD, some tachyarrhythmia or bradyarrhythmia, now assess your patient with these 5 Ds. Whether the patient is in distress, AMS means altered mental status, discomfort, chest tightness, chest pain, or deficient hypotension, or drenched, totally sweating, shock like things, then it's nothing but pulmonary edema or hypoxia is there. And it's peri-arrest, like peri-arrest, suddenly the patient will not respond to you, dying signs of shock. These are all 5 Ds. So find out your 5 rate, rhythm, P waves, PR, QRS. Next, assess your rate. On the basis of this only your treatment goes. Patient is stable, treatment is different. Patient is unstable, patient is different. The treatment is different. Now we'll see one by one all the rhythm. First we'll discuss 3 fast killers, tachyarrhythmias. Tachyarrhythmia divided in 2 groups, narrow complex, broad complex, on the basis of QRS complex. Narrow, anyone can name any narrow? SVTs, AF, flutters, MAC, these all are narrow. Wide, anyone can name something? Come on. Ventricular fibrillation, ventricular tachycardia, those are the pointers. So on the basis of that, we will decide. So first, which one is killed fast? SVT or VF? VF. Which one will kill fast?